A sleeping human can generate sounds loud enough to penetrate walls. This noise is the direct acoustic result of heavy breathing and rapidly vibrating tissue in the upper airway. To understand what is actually happening mechanically, we have to look past the noise and examine the underlying biometric data. This is a polysomnography tracing showing a highly active audio channel paired directly above a completely stable oxygen saturation channel. This pattern defines primary snoring. It is a strictly acoustic phenomenon, caused entirely by the physical vibration of upper airway structures as air passes through them. While noise suggests distress, actual lung function remains intact without significant airflow reduction. Looking closely at the stable oxygen channel, we see no pathological markers. There are zero apneas, hypopneas, or gas exchange abnormalities. Because the underlying physiology remains stable, the primary symptoms reported are rarely medical. Instead, patients typically present with bed partner complaints regarding the noise, alongside occasional dry mouth. Without the excessive daytime sleepiness that characterizes actual sleep disorders, primary care physicians often dismiss the condition entirely as a harmless nuisance. While it is physiologically benign, that dismissal misses a crucial biomechanical reality. Primary snoring is a clear mechanical indicator of baseline upper airway resistance and structural instability. This diagram shows a sagittal cross-section of the awake human upper airway. Notice the stable positioning of four specific structures: the soft palate, the uvula, the tongue, and the pharyngeal walls. As long as the patient remains awake, this anatomy forms a rigid tube. But during sleep, these exact structures become the mechanical points of failure. The process begins with a neurological trigger. As the brain transitions into sleep, it initiates a systemic decrease in muscle tone throughout the body. Deprived of active muscular support, the walls of the airway lose their rigidity. The passage transforms into a highly collapsible tube. This introduces the principles of fluid dynamics. In a wide, rigid airway, air flows in smooth, laminar lines. But when that same volume of air hits the newly narrowed choke point, it breaks apart into chaotic, turbulent vectors. This turbulence transfers physical kinetic energy directly into the surrounding relaxed soft tissues. Bombarded by this kinetic energy, the soft palate and the uvula begin to rapidly oscillate. That rapid physical oscillation creates sound waves. This is the exact mechanism of snoring. Yet, despite the chaotic turbulence and the aggressive vibration of the tissues, enough air still navigates the passage to maintain normal oxygen saturation. Primary snoring is ultimately an acoustic phenomenon, driven entirely by the predictable fluid dynamics of air forced through a narrowing, unstable cylinder. This baseline instability of the sleeping airway is delicate. It is highly sensitive to external physical variables that can compress the tube further. The most common variable is body position. When a patient lies supine, on their back, gravity pulls the relaxed tongue backward, further constricting the available airway space. As the patient enters deeper, more restorative stages of sleep, muscle relaxation increases, the tissue resistance drops, the turbulence rises, and the snoring naturally becomes louder. We can also map risk factors like obesity and a large neck circumference directly onto this model. These present as external mass loading on the neck, pressing inward and compounding the gravitational collapse. Chemical risk factors behave similarly. Sedatives and alcohol artificially depress the baseline muscle tone even further, removing what little structural integrity the airway had left. Finally, if nasal obstruction forces the patient to breathe through their mouth, it alters the ideal aerodynamic trajectory, mechanically increasing the turbulence striking the soft palate. Each of these clinical risk factors acts as a direct physical force multiplier of airway resistance. This split-screen matrix illustrates the critical diagnostic boundary between simple tissue vibration and total respiratory obstruction. The mechanical threshold separating the two is absolute. Primary snoring, shown on the left, involves only partial airway narrowing. Obstructive sleep apnea, on the right, is defined by complete structural collapse. Looking at the airflow vectors, we see continuous movement on the left. Primary snoring features zero airflow cessation. On the right, the vectors hit a dead end. The airway is sealed off. This directly controls gas exchange. The tracker for primary snoring maintains a steady line of oxygen saturation. The OSA tracker plunges drastically into desaturation as the patient fails to inhale oxygen. To survive the OSA event, the brain triggers a forced neurological arousal, visibly spiking on the right tracker to instantly restore muscle tone and restart airflow. The primary snorer simply sleeps through undisturbed. These extreme internal structural differences manifest as entirely distinct daytime symptom profiles. Because the primary snorer maintains oxygen and avoids neurological arousals, they wake up rested. They completely lack the severe, excessive daytime sleepiness that haunts the fragmented sleep of an obstructive sleep apnea patient. The clinical line between a noisy nuisance and a dangerous pathology comes down to a simple physical distinction: the difference between a vibrating tube and a collapsed one. Whenever a patient presents with heavy snoring, a formal sleep study is mandatory to rule out obstructive sleep apnea and confirm the airway is remaining open. Once primary snoring is confirmed, this flowchart maps targeted treatments to mechanical points of failure. Positional therapy encourages side sleeping to negate gravitational pull. Highlighting the oral appliance node, these devices increase airway space by advancing the lower jaw forward. Upstream, nasal strips or targeted sprays reduce nasal congestion, lowering the initial airflow resistance and promoting a smoother, laminar flow before the air hits the soft palate. In select cases, surgical options are utilized to permanently correct the anatomical structures, physically removing excess tissue that contributes to the vibration. Effective clinical treatment for snoring is an exercise in applied physics, identifying the specific mechanical failure in the airway and introducing a physical force to reverse it. For most patients, primary snoring is a stable condition. It frequently improves with basic lifestyle modifications, like weight loss and reduced alcohol intake before bed. However, the condition requires longitudinal monitoring. If the volume or frequency of the snoring progressively worsens, the patient must be clinically reevaluated. The primary internal red flag is the onset of daytime sleepiness. This indicates that the turbulent airflow is no longer sufficient and gas exchange is finally being compromised. The ultimate external proof of progression comes from bed partner reports of witnessed apneas, moments where the loud snoring suddenly stops, followed by a gasp for air as the airway collapses completely. Snoring is the first physiological alarm of airway instability. Monitoring its progression ensures clinical intervention happens early, long before partial tissue resistance crosses the threshold into total pathological obstruction.